Good evening, everyone, and welcome to today's session. I hope you chisel through the neurology 30 classical clinical minute-based questions, which are also image-based. Another 13 days before we are out of this lockdown. But during this phase of hibernation, are we able to make the best use of time by doing more amount of revision at the comfort of the home? So please join daily live interactive broadcasted session on the YouTube with Dr. Murli Bharadwaj and get inspiration to read, pick up the high-yield topics, strengthen your concepts by going back to the online MBBS.com video library and doing the revision of the high-yield topics, MCQs, taking mock tests and checking how good you are. Let's make the great beginning. Good to see Dhanalakshmi, Ayatvani, Yugender, and many more who are all online. Please inform your classmates to join. Pathology of which artery would be most consistent with the finding on this diffusion weighted MRI? A lot of times whenever there is an acute infarct, CT may not pick up, MRI may not pick up, but diffusion weighted MRI can still be able to pick up. So this is how you are able to pick up an infarct. This is a typical lacunar infarct in the basal ganglia. This is the area where you have the basal ganglia. Now the examiner's simple straightforward question is, which blood vessel supplies the basal ganglia? You should be very sure about. The lateral striate arteries, sometimes called arteries of stroke. They are the penetrating branches of the middle cerebral artery that supply the internal capsule, caudate, putamen, globus pallidus. Anyone who is having a long-standing hypertension, they're at great risk of developing these lacunar infarcts because of the lateral striate arteries is what you need to remember. So the answer is the lateral striate artery lead to this kind of a lacunar infarct on the basal ganglia is what you need to remember. See, there are some fundamental things about the imaging of the brain that you have to be very sure about. This is the typical gray matter. So this relatively light colored area is the gray matter. Once more here you have the light colored area which is a gray matter. Whereas the white matter, you are able to see, right? White matter, it is more dark in color. So white is dark, gray is light. That is how you recognize imagologically. A 33-year-old woman presents to the emergency. There is a right facial weakness, pain behind the right ear since the morning. Good to see Pradeep Reddy, Deep Manwar, and many more who are all online. The neurological examination confirms that there is a complete paralysis of the right side of her face. There is a decreased taste sensation on the right side of her tongue. There is an increased sensitivity to the loud sounds in the right ear. That's called the hyperacusis. Whenever the stapedius muscle is paralyzed, we get hyperacusis. The rest of the neurological examination is normal. You have given a short course of steroid and her facial weakness improved gradually over next few weeks. So this is a classical example of a lower motor neuron type of facial paralysis, facial nerve palsy. So facial nerve also provides the secretomotor fibers to the lacrimal glands. That's the reason there is a development of a rightness in her right eye is what you have to appreciate. So what the patient is having is a Bell's palsy. Bell's palsy is a peripheral facial nerve palsy of unknown cause. So what is facial nerve supply? Afferent taste fibers from the anterior 2/3 of the ipsilateral tongue, because caudate tympani is carried by the facial nerve. General touch and pain sensory fibers from a small area around the ipsilateral ear, that is retroauricular pain. And the motor fibers of the facial expression, both upper half, lower half of the face, both of them, ipsilateral facial paralysis. Stapedius muscle, whose paralysis will lead to development of hyperacusis. Also there is a dryness in the right eye because facial nerve carries the parasympathetic secretomotor fibers to the ipsilateral lacrimal glands and provide the lubrication to the eye whenever you are closing the eyelids. So what leads to this lower motor neuron type of facial paralysis? Idiopathic, doctor is idiot, patient is pathetic. We don't know the reason. But even the head trauma, temporal bone fractures, AIDS, Lyme disease, sarcoidosis, brainstem lesions, there are the various underlying causes for the development of Bell's palsy is what you need to remember. A 46-year-old woman, keep punching the answers, doctor. Keep punching, right or wrong. I always like Pradeep Reddy. Regularly add some comments. They're really helpful. So, what is the purpose of this live online session, doctor? Very good question. Ayat Vani is asking a question. Sir, how do we tackle this kind of question when they ask in the exam? Very good question. When I used to be in third year MBBS as a medical student, whenever I see my professor of medicine, Dr. Krishna Reddy, used to be our professor of medicine in Kakatiya Medical College, Warangal, quite a mesomorphic personality, always a cheerful, smiling guy. He used to say, and take the history. Exactly, he used to listen only 2 minutes. Then he used to say, okay, get these investigations done, start this treatment. Next. 100 cases he used to finish. I used to wonder how this man knows. A good number of times there used to be a great clinical acumen and rarely there used to be a wrong diagnosis. But when I became a postgraduate, when I became a consultant, I understood that initially we are very detailed, but history is the thumb. Looking at the history, we know how to shoot the answer. So, Dr. Ayat, I like to say, as you keep practicing more and more number of image-based and clinical vignette-based questions, automatically you can start sniffing like a Sherlock Holmes what examiner want and you can be able to crack it. No worries, right? So it is all theory of relativity. If you are in the beginning stage of the preparation, you have not yet practiced at least 2,000 questions, you will take longer to answer. But if you practice around 10,000 questions, you will start sniffing what examiner want in a clinical VNet based question or an image based question in the exam, whether it is USMLE, step 1 or step 2 CK, or whether any exam in the world, MRCP, or any licensing exam. So that's the plan. So let us do more practice. The whole purpose of these daily sessions is how to get that practice. Before we start the class, we give you a set of questions, 30 or 50 or 60 questions for you to answer. Take a pen and paper, sit, race with the questions and answer. Then you see the discussion will be very interesting, right? So good to see 34 online students. Please inform your classmates to join this session, doctor. A 46-year-old woman presents with the chief complaint of paresthesias that started in her fingers, toes, about 10 days ago. From that point of time, there are paresthesias, muscle weakness in her lower legs. Biki Datta is saying, being a second year MBBS student, what should be my approach? Your approach, Dr. Datta, is every day join Dr. Murali Bharadwaj 1 to 2 hours of live online interactive broadcast on YouTube. Most important approach. Okay? Then there is a list of high-yield topics in every subject. If you go to onlinemmbbs.com, I once more want to bring to your quick notice. Once you go to www.onlinemmbbs.com, you have an extensive video library of around 3,000 video lectures. Every day we keep adding 3 to 4 new lectures. There are about 30,000 multiple choice questions. So there is a lot of downloadable PDFs we give every day. You just need to fill your details and then get the PDF of the handwritten notes, etc. Then you have this area called 650 high-yield topic list. You need to, here you get all the topics. In all the 19 subjects, you get the topics. Each topic, a quick 25 to 30 points of theory review. You have the discussion available. So in cardiology, coronary artery disease, hypertrophic obstructive cardiomyopathy, aortic stenosis, etc., etc., etc. Similarly, you get pathology, pharmacology, anatomy, etc. Then you have this 30,000 heart MCQs with discussions. Similarly, you have mock tests. Then you have the second year, first year MBBS, quick theory for passing university exams, right, for your preparation. Then every lecture you have video, PowerPoint, and a quiz. All the 3 are available under every lecture. So be part of this onlinemmbbs.com. So whatever the discussions that we are doing now will go into this USMLE Step 1 coaching videos. Then every Sunday, once this lockdown is over, from morning 9:30 a.m. to evening 5:30 p.m., we have a face-to-face live class in Hyderabad, which is live broadcasted, and all those lectures become archived on every Sunday. Medicine, surgery, gynecology, obstetrics, pediatrics, orthopedics, etc., etc. So please be part of it. So today learning is very easy, doctor, across the country. With the internet, online video library, what is required is a motivation. And that motivation you get in abundance by being part of Dr. Murali Bharadwaj's mission of onlinemmbbs.com. So also inform your friends, please popularize onlinemmbbs.com in the WhatsApp study groups, etc., etc. And invite your friends also. And you get it at the most affordable price. There are some students who say, sir, we can only pay $1,000. We can only pay $10,000. We can only pay 15,000. No problem. And there are students who pay 50,000, 40,000 also, no problem. We are very democratic in our pricing based on the affordability of the student, like a donation. But what we can give a greater value for the preparation of the student, we try our best. Okay? So let us study together every day. Let us see the patients every day. Let us talk to the patients every day. That is how we become a better doctor, good doctor, and a superior doctor. Like that. Now, a neuroconduction study is performed which shows slowed neuroconduction. That means it is a demyelinating lesion. Demyelinating lesion. So, when this disease progresses, what type of acid-base disturbance do you expect? So basically, this patient is having a Guillain-Barre, which is a post-infectious demyelinating polyneuritis. What is the name? Acute post-infectious demyelinating polyneuritis is Guillain-Barre. One of the major complications of the Guillain-Barre is respiratory paralysis. Respiratory paralysis. Carbon dioxide is called inhalable acid. Carbon dioxide combines with water to form carbonic acid, which releases H plus ion. Inhalable acid. If you can't breathe out your carbon dioxide accumulates in your body. That accumulated carbon dioxide combines with water to form carbonic acid, which releases the H plus ion, leading to acidosis. That's the reason hypoventilation leads to respiratory acidosis. Hyperventilation, a hysterical woman comes to your OPD. Hyperventilation, you'll breathe out too much carbon dioxide out of your body. Then opposite, respiratory alkalosis typically occur with hyperventilation, respiratory acidosis with hypoventilation, which occur whenever respiratory muscle paralysis is there. In a case of Guillain-Barre, is what you need to remember. A 5-year-old girl on physical examination, there is a tuft of hair on her lower back. Tuft of hair on her lower back. Ultrasound shows there is no herniation. What is the condition this baby is basically suffering from? She is suffering from spina bifida occulta, is what you need to remember. So now, doctor, spina bifida occulta is caused by a failure of the posterior vertebral arches. The posterior vertebral arches are supposed to close. If they don't close in utero, that leads to spina bifida occulta. There is a tuft of hair may be present at the site of the defect. So if you give folic acid in pregnancy, it can prevent the happening of this. Similarly, vitamin A also has got a protective benefit, is what you need to remember. So, doctor, I'm a visiting professor of medicine in few medical colleges. Today, one of the greatest challenge in medical education system is, if you take government medical colleges, you have abundance of cases, but there is nobody to listen your case presentation. Teachers are a scarcity. Whereas if you take the private colleges, there's a scarcity of cases. Scarcity of cases. Hardly OPD will have very few cases. In fact, medical students outnumber the number of OPD patients. And of course, gone are the days of those wonderful teachers who used to hold your hand and make you to feel the thrill of a murmur, grading of the murmur, or make you to examine the pulse and talk about the history of the patient and differential diagnosis. So then I thought, how do we break this anarchy? After 4 p.m., all students are at freedom, whatever they want they can do. And there are a lot of wonderful clinicians in private clinics who are having at least 20 to 25 cases in the evening OPD. So I spoke with a few physicians among my friends and my students, very busy physicians, similarly gynecologists, obstetricians, orthopedicians, ophthalmologists, etc. I told them, hey guys, the medical student should get an opportunity to spend a couple of hours seeing the cases, talking to patients, and learning at least 1 or 2 cases every day. 1 or 2 case presentations. They said, oh, we will be more than happy to have the medical students come and attend in the evening OPD with us. We will also admit some cases in the morning, and we will also show them Parkinsonism, multiple sclerosis, motor neuron disease, etc., etc. So that gives me inspiration to start, once this lockdown is over, from May 1st onwards, clinical skill training academy. So I'll identify in every city, for example in Hyderabad. Mainly there are 8 branches, doctor. Medicine, surgery, gynecology, obstetrics, pediatrics, orthopedics, dermatology, psychiatry, and ophthalmology and ENT. So those guys said, hey, let them come, the buddies, we will teach. We love to teach, but see, once upon a time, the great clinicians used to work in the morning in government college and evening clinical practice. But today, some of the great clinicians, morning, evening, they are fully busy in outside corporate practice. So they are not opting to join as academicians, but they are academic at the heart. They love to teach. So this clinical skill training academy in Hyderabad, Bangalore, Chennai, Delhi and Bombay, right? So it will be a very affordable cost, something like you attend a clinician for almost all 1 month. Per month it will be about some 2,000 or 2,500 rupees for everyday evening attending clinical observership. Very affordable price. So some of the clinicians said, hey, we don't need money. God gave a lot of money in clinical practice. But this teaching is something that makes us happy. Even if you send free also, we can teach. We love to teach the medical students. So I'm trying to form a consortium of great teachers with an affordable price, so that provides you the clinical observership to learn. Whether the medical college where you are able to learn or not, doesn't matter, right? So that's a plan, doctor. So to that, if we supplement this clinical learning and the online MBBS.com video library, it is a great combination. You are seeing patients every day, you are talking to patients every day, you are presenting the cases, you're also listening to, you're also solving the questions and preparing for the licensing exam. It is a great combination. So please tell your friends, shortly the great revolution is going to start from Dr. Murali Bharadwaj, online MBBS.com. Clinical Skill Training Academy, right? So you can also tell your juniors, etc., etc. So doctor, a 5-month-old baby is crying incessantly without stopping. Neither changing his diapers nor feeding is able to calm him. This morning she became very lethargic, warm. Temperature is 104 degrees. There is a rigidity in the nuchal area. Lumbar puncture had been done. Pradeep is saying, sir, how about clinical hands-on experience? Yeah, even that also. You get, there are clinicians who are ready to teach endotracheal intubations. You'll get a chance to do around 30 to 40 endotracheal intubations, lumbar punctures, intercostal drainage tubes, suturing, assisting the surgeries. If you come forward to learn the skills, there are clinicians I can arrange who can be able to teach you. Absolutely. Now, doctor, lumbar puncture shows elevated opening pressure, elevated protein level in the CSF, decreased glucose, numerous PMNs. What are the most likely cause of this patient's symptoms? E. coli. So you should remember, this patient is having meningitis because fever, headache, nuchal rigidity. And it is more likely to be bacterial meningitis because there is an elevated opening pressure, elevated level of PMNs, elevated protein levels, decreased glucose levels. The three most common cause in the newborns for the development of meningitis: Group B streptococci, E. coli, and Listeria is what you need to understand. A lesion accounting for Wernicke-Korsakoff's encephalopathy. Where is it located, doctor? Mammillary bodies. All your memory, all your emotions. There is a Pepys circuit in the limbic system. So mammillary bodies. So Wernicke-Korsakoff encephalopathy, thiamine deficiency, where there is a confusion, disorientation, anterograde amnesia, not retrograde. Past is remembered, future can be remembered. That's a problem of a alcoholic Wernicke encephalopathy guy who is thiamine deficient. Confabulation. What is confabulation? Pieces, bits and pieces of memory. The patient is trying to join all these bits and pieces of memory and trying to make it into a complete conversation. A good number of times in the viva voce, you are stuck up. You feel that I know this, I know this, I know this. That is confabulation. Oculomotor dysfunction, ophthalmoplegia, and motor ataxia. Basically, the lesion is in the mammillary bodies, is what you need to remember. Which deficit is seen when there is an occlusion of the artery leading to this imaging finding? Wow, this is very important. So this is the territory of anterior cerebral artery. Anterior cerebral artery lesion typically lead to contralateral monoparesis, lower limb monoparesis. So suppose let us say right anterior cerebral artery is occluded. Then that lead to left to lower limb monoparesis. Why? Typically in this area of the ACA territory, if you look at the motor homunculus of the picture, different parts of the motor cortex are for different parts of the body's motor, leg, hand, face, tongue, thumb, etc. You know that picture of that motor homunculus, no? Homunculus. So typically, ACA territorial stroke will lead to contralateral lower limb monoparesis is what you need to remember. So because of this contralateral lower limb monoparesis, what happens to the patient? While he is walking, he is dragging his foot. So, a lot of times people will think, hey, is this elderly man is having some kind of fracture? They will be rushing to an orthopedic surgeon, in fact. But if you do Babinski of that particular foot, Typically, there will be a plantar upgoing. So that gives you a clue that, hey, this is not a fracture, this is not a fracture, this is a neurological deficit. So if it is a left lower limb monoparesis, right ACA territory stroke, right lower limb monoparesis, then left ACA territorial stroke. That is what you need to remember. A 32-year-old man drinking a lot of water, polydipsia, unquenchable thirst. He is also urinating excessively, polyuria, unable to sleep during the night because of the frequent urination, continuous thirst. Urine analysis is showing a low urinary specific gravity. Serum analysis is showing hyperosmolarity. Hyperosmolarity can sometimes be because of hyperglycemia, but there is not really that much of hyperglycemia. And the patient is admitted, thought to be a case of diabetes insipidus, and a subcutaneous vasopressin has been given. And subsequent urine analysis has shown that the urine specific gravity improved, osmolarity of the plasma decreased. That means there is no diuresis and there is water is reabsorbed into the body. So this patient hence is a case of central, because if you give vasopressin, if the diabetes insipidus is improving, then that is central diabetes insipidus. That means your pituitary stopped producing the vasopressin. So there you need to administer desmopressin, which is going to help this patient. So this patient is having central diabetes insipidus, is what you need to remember. In which cranial nerve damage does it lead to ulnar deviation to the right side? Beautiful question. So you should remember palatal arch, uvula. You can see that uvula, no? Uvula, you can see, no? So uvula is supplied by vagus, 10th cranial nerve. Deviation of the uvula to one side implicates LMN type of a lesion contralateral to the side to which the uvula is deviating. Suppose if the uvula is deviating towards the right side, that means left side LMN type of 10th cranial nerve palsy. Uvula is deviating towards the left side, then there is a right LMN type of 10th cranial nerve palsy. Whereas the upper motor neuron vagus lesion will lead to the uvula to deviate towards the side of the lesion, That is what you need to remember. UMN type of 10th cranial nerve lesion, that means bilaterally there should be an interruption of the corticobulbar fibers. Then only you will get UMN type of paralysis. UMN type of 10th cranial nerve paralysis, if only bilateral corticobulbar fibers get interrupted, then that will lead to towards the side of the lesion, upper motor neuron type. Whereas lower motor neuron type, contralateral to the side to which the uvula is deviating, is what you have to remember. 56-year-old man. Wow, I'm so happy to see 40 online classmates across the country. Also, please inform all your friends. Every day, Dr. Murli Bharadwaj does not go to sleep unless he spends an hour or two interactive session, even if it is late night. He loves to spend, inspire you, and make you to go back to the online MBBS.com video library and then do a revision of 4 to 5 high yield topics. The entire medical school, doctor, 19 subjects, physio, biker, micropharma, pathoforensic, ENT, ophthalm, SPM, ortho, pediatrics, medicine, surgery, gynocs, anesthesia, psychiatry, dermatology, radiology. Totally, there are only 953 high-yield topics you have to do the revision. Even if you spend 30 minutes time to finish one topic revision, 450 hours is all, 500 hours is all that you require in the medical school to clear any damn licensing exam, theory. But today's exams are all clinical VNet-based exams. They expect also you to have a depth in clinical knowledge. So that you will only get by seeing 3 to 4 patients every day and solving at least 10,000 clinical VNet-based questions. So that is the whole purpose of our everyday session. Every day we discuss about 50 to 60 clinical VNet-based USMLE step 1, step 2 CK type of questions that will give you enough amount of practice which is required to substantiate your theory fundamentals, right? So 56-year-old man complains of the vision problems past 3 days. He has AIDS. His CD4 count is very low. It was only 18 3 months ago. He stopped taking antiretroviral. Very bad, very bad. Neurological examination shows that problem with his speech, with his memory, with his coordination. His symptoms rapidly worsened, and 2 weeks later he died. What is the most likely cause of the death? So you should remember, it is progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy is what he is suffering from. That is because of the JC virus. It is the reactivation of this dormant virus in HIV positive individual that lead to deficit in speech, memory, coordination, visual problems, very rapid decline of the neurological function leading to coma and to the death. Typically, only 2 weeks from the onset of the visual loss to death, 2 to 3 weeks. If you look at the brain, what is meant by leukoencephalopathy? Leuko means white. That means white matter got destroyed. So there will be multiple areas of demyelination throughout the white matter of the central nervous system. No specific treatment for PML is what you need to remember. A 46-year-old woman presents with gradual onset of involuntary limb facial movements, mood swings, trouble with her memory. Even this memory loss, mood swings, etc. There is also history in her mother, but that her mother had an onset at 55 years, this lady has an onset at 46 years. That means as the generation is progressing, there is a early onset, more severe clinical deterioration. That is classical, as Pradeep Reddy rightly says, Huntington's disease. This is called phenomenon of anticipation. So Huntington's is a atrophy, gliosis of the caudate nucleus is what you need to remember. So there will be coliform movements, dystonia, altered behavior, dementia, all because of the CAG repeat, trinucleotide repeats. What is the chromosome number? Chromosome 4p. And caudate involvement lead to hyperkinesia. And reserpine sometimes is known to minimize these hyperkinetic movements. A 68-year-old man presents with a progressive memory loss, cognitive decline, His wife says, whenever he goes into the neighborhood, he forgets the home. And instead of him, she now pays the bill because he's unreliable. Similarly, she also states the patient's appetite, weight, sleeping pattern, energy, they have not changed. But he is less interested in hobbies, he is not enjoying them. And you have done a mini mental status examination, MMSE, mini mental status examination. That is what I am telling you. You should actually meet 10 to 15 dementia patients in the OPD. So be part of Dr. Murali's Clinical Skill Training Academy. I will talk to some of my neurology buddies and friends and tell them, hey, medical students are going to come. Line up the Alzheimer's, line up the Huntington's, line up the Parkinson's, line up the multiple sclerosis. They will all line up for you, the patients. Patient is the God. He came from that planet to teach you what dementia looks like. So you have to be very, very courteous, kindful, communicative, empathizing to the patient. And all these patients of the Clinical Skill Training Academy of Dr. Murali Bharadwaj and his associate clinicians, they're all private paid patients also. Any patient, you need to be courteous basically. So they're offering their body for you to examine and learn. So you talk to 10 patients of dementia. It is equivalent to reading Harrison's Internal Medicine for 100 times. Let me tell you, right? So mini mental status examination, MMSE. How to do the MMSE? What are the components of mini mental status examination? How to look at orientation, memory, consciousness, attention, recall, all the components of MMSE. You should practice on a patient, right? So his MMSE score typically is 30 is the higher score. 16 by 30, that is decreased. And MRI is showing prominence of sulci, atrophy of the gyri, and prominence of the sulci. This much of prominence of sulci. That means there is a degeneration of the brain. So, what else this patient is going to develop for a period of time? Depression. So Alzheimer's is most likely diagnosis and the presentation, lack of stroke or Parkinsonism symptoms or a stepwise progression of illness. So there are the important clues. So what are the various causes leading to dementia, doctor? Whenever patient is having dementia, memory loss, you should look, are there any reversible causes of dementia? If there are reversible causes of dementia, you are very happy man. Why? Because you correct it, dementia reverses. You correct the thyroid, dementia reverses. You give vitamin B12, dementia reverses. You treat syphilis, dementia reverses. So, thyroid dysfunction, vitamin B12 deficiency, syphilis, hepatic encephalopathy, they're all the reversible causes of dementia. So, doc, what in this type of fracture, which structure is going to get affected? So, what is this type of fracture, doctor? You are able to see mid-shaft fracture. What passes here? Radial groove in the mid-shaft fracture of the humerus. Through the radial groove, who passes? Radial nerve passes. So there is a radial nerve injury. That is what you need to remember. 28-year-old man 28-year-old man with a history of intractable seizures has been recently switched to a new anti-seizure medication. Very good to see 40 students online. Hey, please tell your friends, bring another 4 to 5 friends. I want to see this class crowded with 2 to 300 students every day evening. Will you give me that promise? Our students are our best brand ambassadors. I'm so happy yesterday there are a group of students who have sent their classmates. They're all in the WhatsApp group of their classmates. So they took a screenshot of all their WhatsApp classmates and sent to our helpline. So please note our helpline is 900-868-356. Is our helpline number 900-868-356. So almost all about 2,000 student numbers came from different parts of India. Our people have sent a SMS feeler, WhatsApp feeler to them. Hey, come and have a look at onlinemmbbs.com video library. A good number of them walked in, and now they all joined the onlinemmbbs.com. So always I say our students are our brand ambassadors. We don't need to really advertise and unnecessarily waste money on advertising, right, Doc? So bring some of your friends every day evening. We will all study together, right? A 28-year-old man with intractable seizures has been initiated on a new anti-seizure medication. There is a maculopapular blistering lesion with a central erythema surrounded by a halo. There are also these lesions on the gums and anus. So what is the most likely medication would have led to this? So what are these lesions, Dr. Stevens-Johnson? This is Stevens-Johnson syndrome. So when I was a postgraduate long ago, I have presented about 60 cases of drug-induced adverse drug reactions, where a good number of, sometimes even simple diclofenac also can lead to development of Stevens-Johnson. Simple trimethoprim sulfamethoxazole given for UTI, urinary tract infection, may end up the patient in Stevens-Johnson. Even a paracetamol sometimes will land the patient in Stevens-Johnson. You don't know which patient will go into that. You're lucky if none of your patients have gone into that. There are a good number of times, unfortunately, doctors have been sued for the adverse drug reactions of Stevens-Johnson. But most of the times, judge will say, it is not in the control of the doctor also. The literature says that Stevens-Johnson can come to anybody with any of the English medicine, any allopathic medicine. So, but carbamazepine is notorious to lead to this, Stevens-Johnson. And also, carbamazepine, what are you going to remember, doctor? Stevens-Johnson, a granulocytosis, bone marrow depression, hyponatremia, because carbamazepine will lead to the development of inappropriate ADH secretion that can land the patient in hyponatremia. So Stevens-Johnson, hyponatremia, granulocytosis, they are the three things you need to remember when we talk about Stevens-Johnson. The wife reports that her husband is right-handed. But he can no longer balance his checkbook or count his money. He has a difficulty to count the individual fingers. He confuses left and right sides. Although he can read without effort, he has an extreme difficulty for writing. Reading is okay, but writing is difficult. So where is the damage in the brain is a very important question. It is typically Gersman syndrome, which is typically seen in the dominant hemispheric angular gyrus lesion, will lead to Gersman syndrome. Now tell me, doctor, what are the 4 classical symptoms of Gersman syndrome? Number 1, inability to distinguish right from the left, right from the left. Is it the right? Is it the left? Number 2, inability to identify the fingers. A writing disability, agraphia, dysgraphia, and a lack of understanding the rules of calculation or arithmetic. Acalculia. In fact, if you look at a lot of kids nowadays, because of this lockdown, normally also I spend a good amount of time studying with, whenever I get time, to study with my younger son and his classmates who are in, now entered into 6th class, doing arithmetic. Some kids will pick up arithmetics very easily. Some kids will struggle to know that, okay, 1 million has 7 digits, 1 billion has 10 digits. So they have a challenge, normally only. Even as medical students also. Some students will have difficulty to remember. Some students, medical students, have a difficulty to understand the logical sequence of reasoning-based concepts. But with all those learning disabilities, we pass medical school. In fact, there was recently a paper published on learning disabilities among the medical students. But one can overcome the learning disabilities, first of all, identifying what are the disabilities that one has got. Some have a challenge of communication. Some are very much an ease of communication. But some, after getting trained, will become better communicators. So everything, God's creation is very mysterious, right? So the reading ability remains intact. They can read, read very nicely. But you ask them to calculate, no, I can't calculate. But you ask them to read, they can read. So that is a challenge. So quite a good number of times, Gersman is angular gyrus, where there is a visual association cortex. And the visual association cortex can sometimes lead to contralateral homonymous hemianopia or a lower quadrant anopia. Lower quadrant anopia. So lower quadrants, upper quadrants in the visual field. Lower quadrant anopia, only one quadrant get affected. Lower quadrant anopia can be associated. Now, 42-year-old women presents with 6 months history of episodic nausea, vertigo that lasts 4 to 5 minutes. Her symptoms intensified over the past week. There's a buzzing, tinnitus in the right ear. And on physical examination, otherwise healthy, normal vital signs, but there's a mild sensorineural hearing loss in the right ear. No nystagmus. There is a vertigo, tinnitus, but no nystagmus. And there's a unilateral hearing loss on the right side, especially for the low frequency range. So what do you have, doctor? Deafness, vertigo, tinnitus. This is the combination that you typically have in this case. There is a classical feature of Meniere's disease, which is endolymphatic sac hydrops, is what you need to remember. Now a challenge is this the migraine? Is it the mania? Is it the mania? Is it the migraine? Is a big confusion. But auditory dysfunction, deafness is a clue. Meniere's only will have deafness, not the migraine. Meniere's common between 30 to 60 years. Episodic vertigo, along with progressive low frequency sensory neural hearing loss, is an indication that it is a Meniere's disease but not migraine, is what you need to understand. There is also oral fullness, pressure, tinnitus. So the volume of the endolymphatic system is increased because of the malfunction of the endolymphatic sac. Normally endolymphatic sac, there is a filtration, excretion of the endolymph, but it is unable to filter. It got collected, it led to hydrops, it led to fullness, it led to tinnitus. That's what you need to remember. A 38-year-old man presents with headaches. These headaches occur in the night without warning. Man with headache, cluster headache. Woman with headache, migraine. You are not going to forget, right? Once more, tell me. Man with headache, cluster. Woman with headache, migraine. A man tossing on the bed, throwing the pillow here and there, crawling on the floor. Cluster headache. A female buried her head under the pillow and said, "Hey, don't put the light, man. Don't put the light, man. My headache is severe, man." She's migraine. Okay? So that's very important. So tomorrow, in such a large clinical vignette, when you go for USMLE step 1 or any licensing exam, man with the headache, you should only think excruciating headache, periorbital, autonomic features like rhinorrhea, continuous tears, excessive lacrimation. That should make you to think of the cluster headache. Patient will say, "Oh doctor, somebody is tearing the flesh out of my eye." Think of cluster headache. That is very important. Analgesics are not giving any improvement, no relief. But sumatriptan, not only in migraine, even in cluster. Verapamil is used for prophylaxis. One more thing, oxygen therapy also will improve the cluster headache. So what is the most likely diagnosis? Cluster headache. 25 to 50 years, men are affected more than women. No prodromal symptoms, periorbital, excruciating pain. Often it is unilateral. The mean duration is 45 minutes. Migraine people love to remain in the dark, in a quiet room, whereas cluster headache will be running and tossing, stay active. Oxygen, international lidocaine, triptans, they all have the role. And for the prevention, prophylaxis, prednisolone, verapamil, methotrexate for 1 to 2 months. A 52-year-old woman with dysarthria, progressive muscle weakness, bilateral upper and lower extremities weakness. There is no recent illness, there is no weight loss, there is no trauma. There is a marked amount of atrophy of the muscles, even that is involving the tongue muscles. There is a fibrillation of the tongue muscle, that means LMN features. complete atrophy, right? But one classical feature, upper limbs show element features like atrophy, fibrillation, etc. Lower limbs show UMN features like hyperreflexia, Babinski positivity. So the combination, lower limb showing UMN features, upper limb showing element features, that is a very important clue to say it is a motor neuron disease. So, deep tendon reflexes are absent in upper extremities but 3 plus. Hyperreflexic in lower extremities. Upper limbs show fasciculations. Lower limbs show Babinski positivity. Then what is most likely classical feature that you are seeing in motor neuron disease? So, very good. Pradeep Reddy rightly reminds Stephen Hawkins, great physicist. History of Time. He wrote a novel. He wrote a book. Great book. You should read at least once. Finally, before dying, he said, "No God, nothing. We are all like small crap of computers. After the computer doesn't work, old version of iOS Apple phone, you will throw it away. Like that, after we die, they will throw away. We are all just machines," he said. Right? Great physicist, motor neuron disease. There is a movie on that, right? Very good movie. Very heart-touching movie. You should all watch that. Pradeep, what is the name of the movie? Can you also punch? It is available in the Netflix. Keep watching Netflix also. That's how you should overcome the lockdown. So, I'm playing carom board with the kids, table tennis with the kids, and playing chess and spending a good time. Sometimes a forced holiday, there is nothing else that we can do. And this forced holiday also giving me time to spend with you all every day, right? So that's how we should take adversity as an opportunity and rise above the situations, doctor. Right. Theory of everything, huh? Okay. Oh, Pradeep is not a big fan of Stephen Hawkins. Oh, come on. How come? Pradeep Reddy is our most popular physician in making, and yeah. So, neuronal loss in anterior horn cells, hence LMN features, and also corticospinal tract degeneration, hence UMN features. Both the things are seen in motor neuron disease is what you need to remember. So what is the drug doctor used to treat the motor neuron disease? Riluzole. Riluzole is what you need to remember. A 45-year-old died after a severe headache. Autopsy, after removing the calvarium on the surface of the brain, there's a frank blood on visual inspection. Even on trying to remove it, it is not getting removed. So you know very well, there is a dura, there is a arachnoid, there is a pia. Pia is adherent to the brain almost. Between the pia and the arachnoid, you have subarachnoid hemorrhage. Almost even that is also adherent to the surface of the brain. So whenever you are deeply washing, you are trying to wash the dura, how will you be able to remove the blood of the, which is underneath the arachnoid? You can't. So typically this area is called Sylvian fissure, doctor, in the brain. So in the area of the Sylvian fissure, if the blood accumulates, it is not extradural, it is not subdural, it is subarachnoid is what you need to remember. So the blood filling the subarachnoid cisterns and extending into the Sylvian fissure bilaterally, enlarged temporal horns and a trace of the blood in the intraventricular area. So these are all the clues to say that it is subarachnoid hemorrhage. I asked for 200 students and you brought 44 online. Thank you very much. So please, tomorrow when you come to the class, bring 200 students. That's going to be your promise. Now, doctor, what is the cause for the subarachnoid hemorrhage? It is a ruptured aneurysm between the two anterocerebral arteries. You have anterocommunicating artery. A perianeurysm over there ruptures and lead to the bleed is what you need to understand. A 44-year-old man presents with a persistent numbness in the right jaw, lower face, MRI. What is it showing, doctor? It is showing the cerebellopontine tumor. So this is pons, this is cerebellum. So cerebellopontine tumor, which is acoustic neuroma. So the cranial nerve involved in this case, how does it exit the skull? It exits through foramen ovale. So the foramina of the trigeminal nerve divisions can easily be remembered by standing room only, SRO. That is superior orbital fissure. Through that what will pass? Ophthalmic division of fifth cranial nerve. Room is foramen rotundum. Rotundum. So maxillary division passes through rotundum. That's called. You can also otherwise remember rotomax. Rotomax is a pen. Rotundum is maxillary. Maxillary division. Ovale. Through that passes third division of the trigeminal, which is mandibular division, passes through ovale, is what you need to remember. Thank you, Dr. Abdul Majid. I am honestly thankful. Yesterday, Dr. Abdul Majid has sent almost 400 doctors' data, the WhatsApp screenshots of all his friends among the medical students and doctors. And our helpline approached them, telling them, hey guys, come and have a look at onlinemmbbs.com and our free YouTube live sessions. So thank you very much, Dr. Abdul, for that. I'll be grateful. I'm grateful to you. So doctor, a 3-week-old infant has presented. Presented with what, doctor? Hydrocephalus. There's an episode of Group B streptococcal meningitis. You have given intravenous antibiotics. What is the mechanism that meningitis lead to development of hydrocephalus? All the CSF, ultimately, it gets drained through the arachnoid villi. Arachnoid villi. So, it is the fibrosis of this arachnoid villi in case of meningitis will impair the absorption of the CSF. That lead to the development of the hydrocephalus is what you need to remember. Now, doctor, what is the area involved in vomiting in this classical picture? So you should know, this is pineal gland, doctor. This is subfornical organ. This is OVLT. And this is posterior pituitary. And this is area postrema. Area postrema. What is the importance? Common to all these organs. These are all called the circumventricular organs. That means entire brain is separated from the blood by a blood-brain barrier, but these things are exposed. They don't have a blood-brain barrier. So they are exposed to the changes, chemical changes, etc. that happen in the blood. So area prostrema in the medulla is the one that mediates the vomiting sensation, is what you need to remember. A 29-year-old woman presents with a 4-month history of difficulty reading, pain in the right eye, paresthesia in her hands and legs. Oh, difficulty reading, optic nerve. Pain in the right eye, okay, painful optic, ophthalmopathy. Paresthesia in the hands, that involves nerves. See, that means anatomically, where is the optic nerve, where is the peripheral nerve? Anatomically separate from each other, but both of them not involved. A similar episode occurred 2 years ago, but it was self-limited. That means the progression of the clinical features also are spaced by time, spaced by geography, anatomy, anatomical location. So spaced by time, spaced by geography, that is the feature of multiple sclerosis, is what you need to remember. So during the examination you have seen there is a hyperemia and edema of the right optic disc. There is a hyperreflexia. Now the question is, what do you expect in multiple sclerosis? There is a lymphocytic macrophasic infiltration with areas of demyelination. So optic neuritis, recurrent paresthesias, they are the things that you see in multiple sclerosis, is what you need to remember. So temporal lobe lesions, injuries, they cause damage to the lower division of the geniculo-calectrine tract, that is a Mayer's loop. And these radiations contain the input from the inferior retinal quadrants, which represent superior visual fields. So that means the lesion is behind the optic chiasma, resulting in quadrilateral upper quadrantopia, which is typically a feature of the demyelination. A 78-year-old man, autopsy of the brain is being shown in the figure. The patient is also having motor symptoms without evidence of dementia. So what are these inclusions, doctor? They're the typical melanin containing neurons with the pink staining inclusions. What are they called? Lewy bodies. They are called Lewy bodies. So typically it's called a Parkinson plus disease. Lewy bodies are found in two kinds of conditions. One is Parkinson and Lewy body dementia. So what does Lewy body contain? They contain aggregation of a protein called alpha-synuclein, is the one which is there in the Lewy bodies. So Parkinsonism, what do you have? Resting tremor, which is asymmetrical, cogwheel rigidity, bradykinesia, postural instability. A 72-year-old woman, right-sided Horner syndrome, right-sided facial pain, hoarse voice, dysarthria, diplopia, numbness, ataxia, contralateral impairment of the pain and temperature in the arm and leg. Classically, this is all talking about lateral medullary syndrome of Wellenberg. Lateral medullary syndrome of Wellenberg. So the dorsolateral quadrant of the medulla with nucleus ambiguous. Look, nucleus ambiguous is the motor nucleus of the cranial root end. And the inferior surface of the cerebellum. They are all the ones which are involved in lateral medullary syndrome. What is lateral medullary syndrome due to? It is due to the occlusion of the pica, posterior inferior cerebellar artery. So that leads to ipsilateral face and contralateral limbs numbness. Ipsilateral face because your trigeminal nerve brings the sensation, pain sensation, ipsilaterally. It won't decussate. Right side trigeminal, right side pain temperature. Left side trigeminal, left side. Whereas your spinothalamic tract, lateral spinothalamic tract, right side lateral spinothalamic takes the pain and temperature towards, is bringing it from the left side, right? Because left side, it decussates and passes on the right. So There is a contralateral limb pain and temperature loss and ipsilateral phase. Diplopia, dysarthria because of nucleus ambiguous involvement. Ipsilateral horniness because sympathetic pathway passes along the lateral medulla ipsilaterally. So, pica supplies the dorsolateral quadrant of medulla, nucleus ambiguous, and inferior surface of the cerebellum is what you need to remember. Very good. Pradeep adds a very good point. If parietal lobe damage, then it would cause contralateral lower quadrant anovia. Absolutely. 76-year-old man, old woman, worsening low back pain. Pain radiating to anterior thigh. So a pain which is radiating to the thighs, to the buttocks, means it is a radicular pain. That is the movement from the spinal cord. Once the spinal nerves leave the spinal cord, they are called radicals. Any compression of that lead to radicular pain. The pain affected her for nearly 4 years. It occurs during walking, prolonged standing, but relieves by rest and sitting. Rest and sitting. That's called claudication. Even standing also lead to pain. So there are two types of claudication, doctor. Vascular claudication, neurogenic claudication. Now let me make myself a bit clear. Let me get one slide to talk about this. So, doctor, there are two types of claudication. Claudication means a pain in the lower limb, right? In the limb. So one is called neurogenic claudication, other is called vascular claudication. If the person smokes, if there is a atherosclerosis of the peripheral vessels, that is peripheral vascular disease, then there is that atheroma occludes the vessel and there is a decreased blood flow. So whenever he walks and exercises, he needs more blood flow, but this atheroma is preventing that. That's the reason he gets the pain. So if he stops walking, the pain relieves. So what is that called? Vascular claudication. Neurogenic claudication, why does it occur? Typically, if the person is standing, prolonged standing, then whenever there is any stenosis of the spinal canal, then the compression on the nerve radicals will be more on standing. So whether you are walking or standing, both the times if the pain is there, that is neurogenic. But if you have the pain with walking, but it doesn't happen when you are standing, when you stop walking and stand, then that is more likely to be vascular claudication. Got it? Very important. That is the reason I am telling you. You should listen to patient's story. You should meet up one spinal stenosis patient and listen to his story of claudication. You should also look at one case of atherosclerosis in a smoker and listen the story of vascular claudication. One time you listen, doctor, forever in your entire life you don't forget. Okay? So, join the Clinical Skill Training Academy if you are in final MBBS, final year of medical school, or even second year of medical school. Doesn't matter. By 4:30 p.m., say goodbye to your medical college, you come back to home. I will arrange a lot of clinicians nearer to your home. I am speaking to a lot of clinicians. Go to their clinic. They will demonstrate you a couple of inpatients and few cases in the OPD. Talk to the patients, listen to the patients, understand the history, and you can also present to them, and the clinician will take a little time to explain you also about that case. So every day you do that, 2 to 3 hours you spend with a clinician. I will arrange nearer to your home who has a private clinic. But only when you combine the knowledge, learning, and this live online clinical Vinet-based USMLE styled questions practice, if you combine them with the clinical exposure every day, deadly combination, doctor. Medical school learning is supposed to be very proactive, very interesting. You know, we are all managing human disease. See, if you take ophthalmology, in ophthalmology clinical posting, hardly students learn when they go to the college, unfortunately. But you go to any private, I will arrange the private clinician for you. He will show you few cataracts, few foreign body removals, few glaucomas, few diabetic retinopathies. You have a clear objective, what I am going to learn. You supplement that with your studying and online MBBS.com video library, it's a great combination. Sharath is saying, sir, any possibility to start in Visakhapatnam? Why not, Sharath? I will start it in Visakhapatnam. One of my students, she is an eminent obstetrician in Visakhapatnam. And there is a great urologist, Dr. Satish Babu. He is MBBS, MS General Surgery from JIPA. And he did MCS Urology. Excellent teacher, Dr. Satish Babu in Visakhapatnam. Today morning only I spoke to him. Hey, I told, he is my buddy friend. Hey, Satish, I'm going to send you the students. You are going to teach them hydrocele, hernia, getting above swelling, getting below the swelling, transillumination, varicoceles, abdominal hernia, ascites, etc., etc. He said, hey, I'll be more than happy. Come on, let the buddies come to the clinic. I said, they will be able to pay for an observership for about a month, around 2,000 or 2,500 rupees of observership fee. He said, even if they don't pay also, I love to teach. He's a private practitioner, a top consultant in Apollo. So what I'm trying to tell you, doctor, if you are prepared to learn, very good. Sharath is saying, sir, we know Dr. Satish Babu. He's a great teacher. He was my junior in medical school and a very, very great friend. So, like that, I have friends in Mumbai, Delhi, Kolkata, Bangalore, Chennai, Ahmedabad, Warangal, Vijayawada, anywhere. If you guys come forward, I can arrange. Along with that, we will provide you the online MBBS.com video library as a combination. Is a deadly combination. Learn the theory, learn the concepts, practice MCQs, practice clinical vignettes on the online MBBS.com video library. Every day we will have a review and also attend the clinical cases in the clinical observership period. So that's the plan. Sarah Fatima, we are going to start from May 1st onwards in Hyderabad. Please inform your friends also. Dr. Murali Bharadwaj, Clinical Skill Training Academy. Let us revolutionize the learning process. This clinical skill training observership is a popular concept in UK, America, many places. Even before 1980s, evening clinics of top clinicians, those days it used to be a practice to attend the evening clinics and learn. Slowly that system got completely gone. The main reason is great clinicians are not joining medical colleges as teachers, unlike the old time, right? But always there are people passionate to teach. The kind of satisfaction in the eyes of a student when he first does suturing, when he first does lumbar puncture, when you taught him, right? When you made him to do the eversion of the sac of hydrocele, when you give them an opportunity to assist you in the cesarean, wow. When you make somebody else to learn the skill, there is an immense happiness and satisfaction. There are many teachers available in the country, top clinicians, who are ready to do that, even though they are not in medical colleges, doctor, right? So that is the story of claudication. So what this patient is having is a neurological, neurogenic claudication, not vascular claudication. That's what you need to remember. So, it is lumbar spinal stenosis is what you need to remember. After this session is over, all these PPTs, this video, everything is made available, doctor, in the online mbbs.com video library. You can happily review that. A 28-year-old woman with worsening anesthesia, weakness in both the upper extremities, headaches. There's no past history, but there are no motor deficits, and but there is a loss of pain and temperature sensation, whereas the position and vibration, dorsal column sensations are intact, but pain and temperature is gone, right? Is lost. What is MRI showing you, doctor? It is showing you dilatation of the central canal. Can you appreciate it? Dilatation of central canal. See, this is all spinal cord, doctor. Here you can see there is an increased opacity. Is it clear for all of you? Right? Now, that is the presence of syringomyelia. So where do you get that? We get it in Arnold-Chiari 1 malformation. Now, doctor, once more, I like to talk a bit about the syringomyelia and what happens in syringomyelia. So, doc, basically, you are having the classical spinal cord cut section. Then you have a central canal. Then you have Andrehorn cells. Here you have posterior columns which are carrying this is the cut section, the vibration and touch. Very good. Dr. Abdul Mazid is rightly saying, when I make my juniors to do the first ASD repair, that's an immense satisfaction. Absolutely, doctor. First time when you do the coronary angiogram, throughout life you have to do the same angiogram. It is like a carpenter job, right? Or a cleaner of a drainage kind of a job. Very good. Any help in Mangalore or Kerala, Gujarat, I am ready. Thank you, Abdul. Thank you, Dr. Abdul. So, posterior column dysfunction is intact. But what happens to your spinothalamic tract, lateral spinothalamic tract fibers decussate to opposite side. This side fibers also decussate to opposite side. So, when central canal dilates, they become affected. So, pain and temperature is gone on the front of the chest. But the position and vibration, dorsal column sensations are not affected. This is basically called dissociate sensory loss. It's called dissociate sensory loss, which typically happens in case of whenever there is any syrinx and dilatation of central canal. So, Arnold-Chiari malformation can lead to syringomyelia, or any obstruction like trauma, tumor, inflammation can prevent the drainage of the CSF and can lead to central canal dilatation. So, what is an Arnold-Chiari malformation, doctor? There is a downward herniation of the cerebellar tonsils. The cerebellar tonsils, this is cerebellum, doctor, this is cerebellum. Cerebellar tonsils will have a downward herniation into the foramen magnum. There is an associated syringomyelia. Then the type 2 Arnold-Chiari malformation versus type 1. What is the main difference? Type 2 is associated always with spina bifida. Type 2 is associated with spina bifida, whereas type 1 are not associated. That's the only difference. So typically, C8 to T1 is the common location where syringomyelia is seen with the dissociated sensory loss. A 52-year-old man presented with unsteady walking. He has a respiratory rate normal, heart rate normal, blood pressure lower, and he is unresponsive to glucose, naloxone. And typically his vitamin B1, thiamine is very low. So what are the most likely diagnosis, doctor? Obviously, Wernicke's encephalopathy. What are the classical triad of clinical features of Wernicke encephalopathy, doctor? Encephalopathy, ataxic gait, along with oculomotor dysfunction is the typical triad of clinical features is what you need to remember. So the last question of the today evening. A 3-year-old boy brought by his mother who discovered a large abdominal mass while giving birth. There is a novel, doctor, called Doctors. Beautiful novel. Doctors is the name of the novel. The author is Eric Segal. Eric Segal. Right? So, it is such a compelling novel. I still remember I lifted it from the library because I can't afford to buy it. I like the novel so much, reading the novel. Eric Segal's Doctors. Please take an opportunity to read that novel. Every medical student and doctor should read it. Doctors by the Eric Segal. That was a novel. First time I read about the tumor when the mother is a pediatrician in that novel. She herself, while giving birth to the child, will discover the abdominal mass. Examination shows that the child has marked hypertension. The urine catecholamine levels are elevated. So, histology, what is it showing? Rosettes. Periorbital ecchymosis, which is basically a classical feature of neuroblastoma. Neuroblastoma is because of the amplification of the N-mic oncogene is what you need to remember. So, neuroblastoma typically happens in adrenal medulla. There will be metastasis, elevated urinary catecholamines. Typically, the children are diagnosed at less than 1 year of age. If the tumors presented less than 1 year, they have a good prognosis. The tumors can show areas of necrosis, hemorrhage, calcification. N-mic oncogene can be seen in neuroblastoma, is what you need to remember. So that brings us to the end of the today's evening, doctor. Thank you so much. And please don't forget to support onlinembbs.com. Please popularize this to all your friends and also subscribe. Become a paid subscriber to the online video library at whatever the price that you can. So please do call our helpline 9000-868-356. And every day, a couple of hours with Dr. Murali Bharadwaj to do the revision. Good night.